Good evening to all. I welcome you all for the TNFOG Bodhana PG series. This is our 9th series. We are conducting this on last Saturday of every month, 5:30 to 7 o'clock. We take one topic and the PGs from one college, and we have internal teachers from the same college and external teachers from different universities. So now I hand over the mic to Dr. Kalpana. Today we have the discussion cases as prolapse and the internals being from Institute of Obstetrics and Gynecology, the director, Dr. Vijaya, and the urologist, Dr. Sita Lakshmi, and the external being Dr. Lily Varghese. She is also a urologist, and Dr. Anuradha Madam, HOD of Chettinad Medical College. Kalpana, you can take over. Thank you.
Thank you, ma'am.
I welcome you all.
Good evening, everyone. It's my pleasure to welcome you all for this Bodhana series, which is a 9th successful program, a great initiative by TNFOG Secretary Sampath Kumari Madam and President Anjalakshi Ma'am. Now I request Anjalakshi Ma'am to deliver her welcome address. Anjalakshi Madam is the founder president TNFOG, past president of OGSI, governing council member DIPSI. Madam has done PhD in pregnancy diabetology from Tamil Nadu MGR Medical University, recipient of Best Doctor Award, and she retired as a professor in IOG, presented number of papers in national and international conferences, and had undergone research work in GDM, diagnostic test, and OHA in GDM. Over to you, ma'am.
Thank you, Kalpana. Good evening, everyone. I'm very happy to give the welcome address. Dear postgraduates, I welcome this postgraduates who are going to present, Priyadarshini and Pushpa Lakshmi, and the teachers, expert teachers, the internal teachers, Dr. Vijaya and Dr. Sita Lakshmi. They are very good clinician, surgeon, and academician. They will discuss the cases very nicely, and you are actually blessed to have Dr. Lily Varghese as external teacher, who is an expert in the pelvic organ prolapse theory as well as a practical and discussion part, and also Dr. Anuradha, a very good teacher from Chettinad. So my request to the postgraduates is you concentrate on the topic that is now today. It's a very important topic, both for your theory exam as well as for your clinical exam and for your practice later on. Okay, so you concentrate, participate in the discussion, clarify all your doubts. That is very important. This purpose of this Bodhana class is whatever doubt you have, please clarify. Don't think, no, this is a silly doubt. The teacher may think something. So don't have that inhibition. So clarify whatever doubts you have, please clarify it and get the benefit out of this program. So I welcome all the teachers, both the internal as well as the external, and the presenter and the delegate post. Okay, these postgraduates, you can dissipate the knowledge to your friends and other people also. And somebody has asked for this recording of this. We are trying to organize that also. Okay, so with this, the teachers, they can take over. Thank you.
Thank you so much, ma'am. It's my pleasure to welcome our internal examiners, Vijaya Madam, who is a director, IOG, and also treasurer, OGSI.
That is a previous thing, I think.
Okay, past.
Past treasurer, yeah.
Past treasurer, okay. And Madam was a national level master trainer in various programs, NMOC, colposcopy, and safe delivery practices. She has been awarded Best Doctor Award in AICOG 2015, Best Doctor Award from our Honorable Health Minister of Tamil Nadu, appreciation from Honorable Health Minister of Tamil Nadu for managing COVID crisis too. And she has published many papers in national and international journals, and Madam's interest is high-risk pregnancy, infertility, and laparoscopic surgery. Welcome you, ma'am. It's my pleasure to welcome our next internal examiner, Sita Lakshmi ma'am, who is a professor OG, department IOG, Madras Medical College. Welcome you, ma'am. It's my privilege to welcome our external examiners, Lily Varghese ma'am, who is a professor, head of Unit 2 OG department, CMC Vellore. Madam has done certification in urogynecology in 2009 and the observer fellowship in urogynecology in USA. Madam is a fistula surgeon, received awards from various foundations like Fistula Foundation, West Africa. Madam, the area of interest is pelvic floor reconstruction, female congenital genitourinary anomalies and reconstruction, minimally invasive gynecological surgery. She's an undergraduate and postgraduate teacher and examiner, and published various publications in national and international journals. Welcome you, ma'am. It's my pleasure to welcome our next external examiner, Anuradha ma'am, who is a HOD, Department of OG, Chettinad Medical College, and she was a past faculty in various medical colleges, government medical colleges, and previously she was a HOD, Department of OG in Kilpack Medical College, and she was a gold medalist final year when she was doing final year obs gyne, and she has received Best Doctor Award when she was in Kilpack Medical College in 2011. Also received Best Doctor Award from Lions Club. Welcome you, ma'am. I also welcome our presenters, Dr. Pushpa Lakshmi, who is a third year MSOG PG, IOG EGMO, and also Priyadarshini, who is also a third year MSOG PG from IOG EGMO. Over to you.
Thank you, ma'am.
You can start presenting your cases.
Ma'am.
Start, ma. Start. To the slideshow.
Yes, ma'am. You're trying to, ma'am.
Chitrakala.
Yes, ma'am.
What happened, Priyadarshini?
Yes, ma'am. Yes, ma'am.
You can start presenting, ma'am, by
Yes,
the time
ma'am.
the slideshow comes on.
Okay, ma'am. Slideshow came, ma'am. Good evening, ma'am. Mrs. X, a 65-year-old para-3 like 3.
It is not shared.
Doctor, you need to share.
While it is sharing, you can start, because otherwise you'll be wasting time of the discussion, no? Yeah. Full screen?
No.
Good evening, ma'am. Mrs. X, 65-year-old para-3 like 3, belonging to lower socioeconomic status. As residing at Traders, she is a coolie by occupation. She came with the complaints of mass listening for vaginum for past 3 years. The history of presenting illness. The patient was apparently asymptomatic years before. Then she started experiencing mass listening more prominent while coughing and straining, which is reduced only by manually. The symptoms related to the prolapse, the mass is reducible, and she has difficulty in working and day-to-day activities. No history of bleeding, no history of bile discharge per vagina, no history of back pain, no history of weightlifting or constipation. The symptoms related to bowel, bladder, no history of difficulty in ejaculation, no history of frequency, urgency, and dysuria, no history of burning micturations, fever with the chills and rigor, lower abdominal pain, no history of incomplete emptying of bladder, no history of incontinence.
Can I
The
stop
symptoms
you?
related to
Can I stop you here, ma? Priyadarshini, or is it Pushpalakshmi?
Yes, ma'am.
Who's presenting? Okay. Either way, when you started with the socioeconomic status. I wanted to ask you, what is the importance, oneness of the socioeconomic status? Because we should not just say it as a routine. What is the importance of it?
the patient is this patient is belonging to lowest socioeconomic status,
Yes.
which is she's also a coolie by occupation. She is prone to a daily work, ma'am, by weightlifting and heavy workload.
Okay, that is the causation. Now it has already happened. She has a
Yes,
mass which does not spontaneously reduce. So what is the
Yes, ma'am.
importance of knowing what is her socioeconomic status?
By the socioeconomic status, we can know the manual work done by the patient and the nutritional status of the patient.
More than that, it is very important to understand that when somebody is a manual worker, see, in the government hospital, most things are free, you'll provide them diet, everything. But once the post-operative is done, once the surgery is done, she has to go back. You have to find out how is she going to cope post-operatively. Surgery is only a very small segment of your treatment. Post-operative care is equally important. Nutrition is equally important. So if somebody asks you, what is the importance? Just knowing why it happened, very good. But what do you do? What is the solution is what you should be thinking. How can she organize for care? All these things, as you grow as a doctor, you should be thinking of all these things from the patient's perspective also. Okay, now.
And more than that, how many people living together, whether she is alone with the husband, whether she has to share the income, that speaks indirectly about her dietary and nutritional capability of buying good foods. So that is what Lily ma'am is trying to tell you, Pushpa.
And also,
Yes,
is there anybody at home to help her? Because she should not indulge in heavy activities soon after her operation. So, is there any help for her to carry out her even her daily activities? She may need some help for 1 or 2 months. These are the socio-economic aspects that you should in detail ask.
Okay, ma'am.
Thank you, madam. In the next slide, Priyadarshini, in the next slide, you have presented very well. You have said, you gave history of, what is the patient's complaint. And then you've gone to the history of presenting illness. Very good. That is the way every clinical case should be taken. But you started using a lot of technical and clinical terms here. Okay. So you go to the next slide, especially when you started addressing the urinary symptoms. All right. So it should be in more simple layman's language. Of course, you cannot present it in Tamil. She would have been speaking in Tamil. But you should not start using technical terminology. Okay. So that is the second thing. Okay. So that is the second thing I wanted to tell you. Urgency, frequency. Okay. So all these are words which should not be used in history of presenting illness. Why is that? Because that is almost like a diagnosis. You're saying urgency. She has urgency. That word means something to all of us. Okay. So that is more of a diagnostic word which you can use in the summary of your case, summarization. But when it's history of presenting illness, you should not use it. Second thing, what I wanted to tell you is just go to your previous slide. You gave history of mechanical discomfort. You said no history of bile discharge, PV. Yeah, chronic cough, heavy lifting. Now we all know you're talking about pelvic organ prolapse. So we want to know what's happening to the other pelvic organs. This should come lower down on your scale of presentation. Okay. So continue with your case. We may interrupt, madam, if anybody else. I just wanted to point it out before we forget it and move on.
Yeah, I
Okay,
agree
so
with
I
you,
get
no?
annoyed, Lily Varghese, when they keep telling no bleeding, no back pain, no chronic cough. Every time, no, we tell them, don't use so many no's. That they, in a comprehensive way, they should be able to present it.
Yes.
And Priyadarshini, lot of spelling mistakes and grammatical error. Okay, see, you are
Yes.
now presenting, and it goes to throughout India, national level. No, the people are watching at it. So once again, no, you just see whether any spelling mistakes are there. Lot of grammatic error is there. Spelling mistake is there. Okay, you have to give consideration for
In
that
other
also.
words, can you say there is no bladder and bowel disturbances? In that way, you
Ah.
are prompting the examiner to ask you the question for which you know the answer. In that way, you can
Okay,
score
ma'am.
mark. That's what I feel. There is no bladder and bowel disturbances. Then they might ask you, what are the bowel disturbances associated with prolapse uterus? At least you can say stress and urge and other things, so that your presentation will be a little more specific. That's what I feel. Lily, I'm not able to understand in these symptoms. You said some order is not there. No, I don't know whether the
Yes, madam. Dr. Vijay, what I was saying is that we all know the pelvic organs involved. At least mentally, PG should organize themselves to think of all the pelvic organs. So the main organ that is associated along with uterine prolapse is bladder. So bladder symptoms they should present. Then they should present bowel symptoms, mechanical, after the mechanical symptoms, I'm saying mechanical, bladder, bowel, sexual. So once you have said all this, then your list of no's should start. Okay, so know this, know that, important negative history. So that you're telling, so like Vijay madam, Anjalakshmi madam was saying, you're telling the important things first. Otherwise, it sounds like there is no other problem and then the examiner will start asking questions. Okay. So you present it very clearly in the order of importance. All right? Okay. Continue, man. Continue, girls.
Symptoms related to bowel and no history of constipation, no history of incomplete defecation, no history of need for digital evacuation, no history of involvement of status or stools. She is not sexually active now. Moving on to the menstrual history, she attained menarche at 14 years of her age. The prior cycles were regular, 3 to 5 days of cycle for 20 to 30 days of month. She attained menopause 45 years. History of abstinence since menopause. Marital history. She's married at 20.
I want to stop you, Priyadarshini. History of abstinence since menopause. Sexual history is very, very important. You said in the previous slide, patient is not sexually active. Because whenever we are doing pelvic organs, one of the functions is sexual activity. Now again, you said sexual. So the sexual activity history is a part also in your presenting symptoms. You could have said because that should not come along with your menstrual history. All right?
Actually speaking, she has attained menopause at a very early age, 45 years. And then the second point you are telling not sexually active. And then the third point you are now coming not living with the husband. This is not a correct thing. You should say in the first instance itself, patient is separated and hence she is not sexually active. Maybe you could have put it the English in that way, Priyadarshini.
Okay, ma'am. The marital history. She's married at 20 years of her age, not living with her husband. History. Para 3, life 3, the first pregnancy. She is conceived at 21 years of age. The antenatal period was uneventful. She had home delivery, trying the toys, normal vaginal delivery, no prolonged labor and episiotomy. Intrapartum and the postpartum period was uneventful. And second pregnancy, the spacing between pregnancies 3 years, no contraceptive usage in between. This is also home delivery by trimester, normal vaginal delivery, the birth weight also not known, no perineal tear and episiotomy. The postpartum period was uneventful. And third pregnancy.
How do you know no perineal tear? Home delivery by a dye? How can you say no perineal tear? You can say episiotomy is all right.
Yes, ma'am. No, yes, ma'am. No history, normal vaginal delivery. Postpartum period was uneventful. No history of puerperal or internal sterilization. She resumed her activity soon after the postpartum period. The past history. no history of chronic respiratory disease, no history of connective tissue disorders, no history of
Priyadarshini?
neurological.
Priyadarshini,
Yes, ma'am.
just a minute. Okay, in your obstetric history, it is also good, it is just good to say. Now we are trying to find out, like I said, finding the cause of the prolapse is one thing. Now finding the solution is also. So keep the obstetric history more brief and concise. Okay. Saying that even if you do not know the exact weight, she delivered a baby of moderate weight. Exact birth weight not known. So what are you trying to indirectly say is that there was no prolonged labor because of a big baby or excessive damage to the pelvic organs. That is what you are trying to say. Okay. So as Madam said also, you cannot comment on perineal injury, spontaneous perineal injury or tears. You can only comment on episiotomy. So she did not have any undue prolongation of the labor and she delivered at home a moderate sized baby alive and well and no history of any episiotomy or surgical incisions on the perineum. It's fine. All right. Okay. Next. Continue, please.
No, you have not mentioned about early ambulation, ma. In poor socio-economic status, they get up the very next day, start doing heavy buckets and all. Are you going to mention later about that? Yeah, you have to mention.
Mentioned, ma'am.
Mentioned. Okay, okay.
What activity? Yes, ma'am.
Yes.
The past
Not
history, no history of chronic respiratory disease. Yes, ma'am. No history of connective tissue disorders, no history of injectable disorders, no history of previous surgeries and blood transfusions, no history of drug allergies. She is not a case of diabetes, asthma, hypertension, epilepsy, heart disease, and thyroid disorders.
Okay,
family
okay,
history,
stop here, stop
no
here.
history.
Don't hurry.
Yes, ma'am.
Don't hurry. Okay, go back. Go back. Okay, no history of previous surgery or blood transfusion. What surgery are you talking about? Tonsillectomy?
No, ma'am. The previous pelvic organ surgeries
Okay, that
has
is
more
what should come across. Okay,
Yes, ma'am.
surgeries can be many. From CSOM, tonsillectomy to lung issues. Okay, so that's not our concern. What we are talking about is does she have any previous pelvic organ surgery? Okay, whether if it is cesarean section, that is important. If it is previous prolapse repair, that is important. If it is previous cesarean section, in what way will it affect your history or your treatment? How will it help you? If she's
In a
having cesarean sections and then she's having a prolapse.
In the management, we'll go for the vaginal hysterectomy, ma'am. If the patient has a previous cesarean section, there is a risk of adhesions will be present, ma'am.
Okay, so that is what is important. So see, this is why you need to speak about surgeries in and around the pelvis. Okay,
Pelvis,
any bladder surgeries, any bowel, anything like that. Okay, so any pelvic surgeries. So if she gives you a history of a previous pelvic organ prolapse and surgery, what are you anticipating during surgery or during your management? In what way will it change your management?
The recurrence means
okay,
the
so
previous.
Okay, one thing is, you know, a previous prolapse, again, there's a higher chance because tissue is already defective. Second thing, Pushpa Lakshmi, I would also like you to contribute. Okay.
Yes, ma'am. If there is a history of surgery for stress urinary incontinence, can also cause pelvic organ prolapse, ma'am.
Okay, yes. In what way will it help you to know about what the surgeries are or the details are? It is very important because you will be anticipating more adhesions, especially for hystropexy or Fothergill surgery. If something like that was done, you are anticipating more problems and you also have to counsel them regarding other organ damage. You may have bladder adhesions, so you can have inadvertent bladder injury. Okay, so these are things which is very important. So to know pelvic organ surgeries, previous LSCS in and around the pelvis is what we are interested in. Why did you ask about blood transfusions? So what I'm trying to say is you should have a reason for everything that you ask. Now you're not an undergraduate. So if your examiner stops you and asks why chronic respiratory disease, I know you know the answer. Why connective tissue disorder, I know you know the answer. Neurological, I know. So the minute I see a sentence which is not making sense, as an examiner, I will stop you and ask, why did you ask that? So you should have an answer. You should have a reason why you have said that. All right.
Actually, this case, you needn't have asked about the drug allergy and those connected to this tissue disorder, because already she delivered 3 children and she is hale and healthy, 45 years, and those are all irrelevant. That means whatever you have studied in the book, the causes of prolapse, you are bringing it in the history of present illness and the past history. That should not be. It should be relevant to your history. If it is a nulliparous prolapse, yes, I understand. You should ask about the connective tissue disorder and any neurological disorder, any spine surgery. Simply you are asking about drug allergy. What way drug allergy is going to cause the prolapse? Tell me, Pushpa.
Ma'am, if the patient gives any drug allergy, if preparing the case for surgery, we can avoid those drugs in pre-operatively, ma'am, and post-operatively.
Oh, you're going into the IV antibiotic because she has delivered so much and she's living to get healthy. I don't think this is essential, but anyway, I think the presenting should be a little bit different, not like an undergraduate simply from the books copying and making a slide. That's what we mean. As a postgraduate, it should be much more crisp and to the point. Okay. Yeah.
Yes. Okay, ma'am. The family history, no history of similar complaints in the family, no history of connective tissue disorders in the family, no history of cancers in the family history, no history of diabetes, hypertension in the family.
Okay, now I'm going to stop you and catch you again, Priyadarshini. Okay. Does anybody else want to ask her a question? I seem to be asking too much. Madam, Anuradha, madam.
No, it's going well. It's okay.
Okay, I'm just stopping you because when you're talking no history of cancers, what cancers are you referring to? See, I said because you are a postgraduate, I am going to stop you when I see a sentence that doesn't make sense. Okay, because I want to know if you understood the subject. Don't take this, don't get upset, because we are here to just teach you and make your presentation more refined for your exams. All right. Okay. Yes, so no history of similar complaints in the family. What similar complaints?
You mean to say no history of prolapse, Priyadarshini? You mean to say no history of prolapse in the family?
Yes, ma'am.
Why do you say this history? Why do you want to ask this history?
There is genetic predisposition in prolapse, ma'am.
Yes,
according to
the recent
studies, gene defect.
Yeah, according to the recent studies, the pelvic organ prolapse is an autosomal dominant disease, and it is characterized. This is due to the defect in the LAMC1 gene. So that is why you are asking for the family history of prolapse in the family, right? You should know the reason, right? Okay.
Yes, ma'am.
So you should say no history of pelvic organ prolapse in first or second degree relatives. It's a good way.
Okay, ma'am.
Okay.
Yes, okay.
Connective tissue disorder, of course, that is what you're indirectly saying. Okay, no history of cancers in the family. What cancers?
From endometrial cancers, we are going for in a pelvic organ prolapse management, we are going for a hysterectomy for the patient, ma'am. So we have to do the endometrial people sampling. That is a family history. And the CS cervix.
Okay, so I'll stop you here since you seem to know the answer. So you should be very specific. No history of genital breast cancers. Okay, any familial cancer syndromes. We are not talking about cancers all over the body again. Okay, so linked cancers. Why does this make a difference in your management? In a 65-year-old lady, are you planning to conserve the uterus? No.
No, ma'am.
Okay, so why should it make a difference, endometrial cancer? If she's had some postmenopausal bleeding, do you need to biopsy her before? If there is a family history of ovarian cancers, then do you need to remove the ovaries also instead of automatically leaving it behind? So all these are issues. So when somebody is asking you, when you're presenting, you must talk about history of breast, genital, colon cancers. Okay, that is what is more specific. Okay. Or familial genital cancer syndromes. Okay, continue, please.
The personal history, she has consumed mixed diet and no history of social habits. General examination, ma'am. Patient is afebrile, cooperative.
Sorry, Ma Priyadarshini, I apologize. I'm frequently stopping you.
Thank you, ma'am.
Okay. Go back. Why? What do you mean by social habits? Is not man a social animal?
Yes, ma'am.
She goes for weddings. She goes for name ceremony. So when you say social habits, I understand what you are saying.
Saying yes,
Yes, ma'am.
I understand what you are talking is about tobacco usage, right? Are you talking about that? Are you talking about alcohol? What are you talking about when you're saying social habits?
Smoking,
What are social
alcohol.
habits?
Yeah, but the social habits is not correct, Priyadarshini. You should
The
not
word
use
is not
that
right.
in that
Yes, madam.
history.
You should be specific, especially smoking. In village, especially,
Ah,
even
yeah,
ladies smoke.
They smoke.
Why smoking is very, very important in this case. Post-operatively, she may develop cough, which
Yes,
will cause
ma'am.
recurrence of the prolapse.
It
Why
prolapse.
prolapse?
And impair the healing also. Smoking impair the healing also.
Second thing is, if you look at many women, they use snuff, they chew gutka, they may not be smoking. So, use of tobacco either with smoking or non-smoking in nature. Many of them have all these habits, including drinking. Okay, so that is what should come across. The word, so what I'm pointing out to you is the word social habits is wrong. Adverse social practices.
Yes.
Okay,
ma'am.
such as use of tobacco or alcohol. So your presentation should become more refined the next time you present this, all right?
Yes,
Yes,
ma'am.
ma'am.
Okay, continue.
The general examination. Patient is afebrile, cooperative, no pallor, no pedal edema, no lymphadenopathy, no clubbing, no cyanosis, no icterus. The thyroid is normal, rest normal. The gait and the spine normal. The height is 152 centimeter. The weight is 72. The BMI is 31. The weight is the temperature normal. The blood pressure is 126/86. The pulse rate is 86 per minute. The SpO2 is 98% in tumor. The cardiovascular examination. The first and second heart sound has heard, no murmur. The respiratory system examination is normal vesicular blood sound, no added sounds. The parabdomen examination.
Okay,
The
I'm going to
inspection.
stop you
The
again.
abdomen
Like
is
my
obese.
habit is. Okay. Why did you do SpO2?
Chronic obstructive lung diseases, ma'am. The patient is
See,
the corona,
a part
the
of routine
COVID
exam.
pandemic, they got used to that.
Okay, madam. I'm wondering why did she specifically say SpO2? So more because as clinical students, you should be looking, if you're doubtful, look at the respiratory rate, look at accessory muscles of breathing. Is there any signs,
RS
additive
is
signs?
normal. Respiratory is normal. No need to tell about SpO2, ma'am.
Yes.
okay, ma'am.
And if you set it in the post-operative period, I would accept it. Okay. But not pre-operative as a routine saying SpO2 is not acceptable. All right. Okay. Why did you ask about spine and gait?
Ma'am,
Yeah, Pushpalakshmi.
fine for anesthesia, ma'am. If the patient have any lumbar, the spine for anesthesia, we have to see the spine, ma'am. Any spinal deformity is there. The neuromuscular disorders already we have ruled out, ma'am. There is no history of neuromuscular disorders. The gait and spine is normal. We are going to put the lithotomy position. Yes.
Excellent. Okay, so that is good. Why did you ask about thyroid?
Surgical, ma'am. Patient for fitness for the surgery, thyroid profile should be under normal, ma'am.
Okay, very good. Okay, continue.
The parabdomen examination. The inspection. The abdomen obese, umbilicus in midline, no distension. All quadrants moves equally with respiration. No swelling or dilated veins and sinuses. The hernial orifices appears normal. The palpation. Abdomen is soft, not warm, not tender. No mass palpable, no organomedullary. The auscultation, vowel sounds heard. Local examination. The inspection, the external genitalia. The mons pubis, labia majora and minora are atrophic. Pubic hair sparse. A pinkish globular mass of 8 cross 5 centimeter is lying outside the vagina. The vaginal rugosity is lost. No keratinization. No presence of ulceration and pigmentation. No perineal tears.
Okay, stop.
The bimanual examination.
Stop. Okay, Dr. Anuradha, Sita Madam, Dr. Vijaya, you want to ask
No,
something?
no, you can proceed.
I want to ask them something.
Yes.
Madam, what do you mean by pinkish globular mass 8 into 5 centimeters? What is globular? Something that's round, isn't it? What do you mean by saying pinkish globular mass?
I want to say the vaginal, the center field. Vaginal segment, ma'am.
Pardon?
Hypoestrogenism, the skin, the vaginal layer will be dry, ma'am.
Okay, that I accept. Vaginal rugosity is lost. That's the hypoestrogen. Okay. I'm asking you, what is this pinkish globular mass that you're describing? You're a doctor, isn't it? Are you talking about the cervix?
Yes.
Are you talking about a vaginal bulge, which is not the cervix? What are you talking about? You are a
vaginal bulge, ma'am.
Okay, so you must say there's a bulge seen protruding outside the introitus or within the introitus, a vaginal bulge, okay, which appears to be a descent of one of the anterior posterior vaginal segments. On the other hand, you're saying this is a globular mass of 8 into 5 centimeters. That's a large prolapse lying outside the vaginal introitus. So it's the vagina that's everted. Okay, so definitely you can see the cervix, can you not?
Yes, ma'am.
Okay, so what you should say is cervix seen lying outside the vaginal introitus. There is a mass of about 8 into 5 centimeters protruding outside. Okay, which is suggestive of pelvic organ prolapse, which looks like total eversion of the vagina. So you are a OG postgraduate. You recognize the cervix. Okay, you do recognize the cervix, right? You don't need to say round donut shaped something with a hole in the center. Okay, so you have to say cervix seen lying outside as the leading point with the eversion of the vagina to a total length of about 8 into 5 centimeters seen lying outside. Signs of postmenopausal hypoestrogenism is present, such as loss of vaginal rugosity and thinning of the epithelium. So your presentation should be such that when the examiner is listening to it, what is the globular mass? They don't stop and ask you this. Okay, you should know now what you are seeing.
And the pinkish globular mass is the undergraduate, no? Usually in that book only it is given. When we started, we don't know what is it. Then we will ask, how is it a uterus? Then how do you identify because of cervix? All those are basic undergraduates question. The another thing is such a big mass outside. How did you see the perineal tear? On inspection, how did you see the perineal tear? At least after reducing the mass, you are examining, that is okay.
Yes.
Okay, carry on.
Go to the previous slide, please. Okay, so you said like this, okay, mons pubis, labia majora, minora thing. Pubic hair, Anjalakshi madam told you, you must correct your spellings. Okay, yes, because you will be writing your paper presentation. In that, you can put all this. But as a postgraduate, you can say external genitalia appears normal, consistent with postmenopausal changes. Pubic hair is sparse, S-P-A-R-S-E, sparse, which means very little. Okay. So the next slide, as we already said, that should be your description because this is all at UG level, it's acceptable. Okay. Okay, continue, please.
The bimanual examination, the perineal body is 2.5 centimeter. The uterus is mobile. Cornus is free. No adnexal mass is felt, and mass is unable to solve this.
Wrong.
Priyadarshini, first you have to say whether the mass is reducible, not the perineal body. First, you have to check whether the mass is reducible, what is the size of the uterus, whether it is enlarged due to fibroid, whether there is associated ovarian mass, not stress urinary incontinence and everything that has to come after your routine pelvic bimanual pelvic examination. It's not correct.
Yes, ma'am.
Okay, so you said uterus atrophic, you said no stress urinary incontinence. So what are you seeing in your inspection itself before on palpation? Okay, so first you're palpating the mass which is lying outside, then you are trying to reduce it. That time you should document also that the external urinary meatus appears normal. In a 65-year-old woman with postmenopausal changes, what problems can you have at the urethra? Can you mention one problem?
Urethral
Reddish at the external urinary meatus?
The urethral mucosal prolapse also have.
Yes, mucosal prolapse can occur.
urethral hypermobility will be there, ma'am. Due to the supporting
From the
structures.
audience, somebody has answered a caruncle, that is right. Or you can have associated urethral prolapse. So just to say external urinary meatus normal is also important. Okay, continue.
உனக்கும் தந்தாங்களா
And her POPQ values, ma'am.
சாக்லேட்
mute others.
Yeah, continue please.
Our POPQ values, ma'am. The AA point corresponding to +3, ma'am. The BA point is +4 cm. The C point is 6 centimeter. The genital hiatus is 7 centimeter. And perineal body is 2.5 centimeter. The total vaginal length is 8 centimeter. The posterior vaginal wall, the A point is +3 centimeter. The B point is +4. The D point correspond to 5 centimeter.
Okay, so what is your cervical length, your ectocervical length from this? What
The
stage of
total cervical length is 6 centimeter, ma'am.
cervical length is 6 centimeter, ma? Ectocervix.
Ectocervix is 2 centimeter.
How do you measure
It
the
is
C
2
point?
centimeter. It is C.
Yes, ma'am.
Actually, here it is 1 centimeter. Okay, so C minus C is 1 centimeter. So you're saying she is having a postmenopausal atrophic cervix. So the second thing you said is, what stage of prolapse is this? Ordinal staging.
Stage 3 pelvic organ prolapse, ma'am.
Why did you say stage 3? I don't agree with you. What is TVL minus 2? What's your total vaginal length? 8 centimeters.
8 centimeter, ma'am.
Minus 2 centimeters is how much?
6 centimeters.
Okay,
6
is there any
centimeter.
measurement in this grid that shows 6 centimeters?
Cervix is
So what stage is it?
It is more than TVL minus 2.
So it is stage 4. And you are saying your point A is +3, your point AP is +3, and TVL minus 2 is 6 centimeters. So this is almost a total eversion of the vagina. Okay, and this is a stage 4 pelvic organ prolapse if your POPQ is correct. All right. So this is how a quantitative pelvic organ prolapse quantitative system helps people across lines to know or understand what kind of prolapse you are talking about. So this is a stage 4. All right, with total vaginal eversion. Okay, continue.
The rectovaginal examination, ma'am. The rectal mucosa is free. The rectal examination, external anal sphincter tone is normal. The levator ani tone is 3/5 according to modified Oxford scale. The bulbospongious reflex and anal wing reflex are normal. And summary, ma'am.
Okay.
A 63-year-old post-menopausal, she is para-3 active woman. She came with complaints of mass descending per vaginum for past 3 years. On examination, according to the POPQ class stage 4 pelvic organ prolapse, level 2 defect.
Okay, now I'm going to get you into trouble after Dr. Sita Lakshmi and Anuradha Madam and others ask questions. Okay, so go back. So you said something level 2 defect. Okay, and go to your previous slide, please.
இந்த மேல தண்ணி ஊத்தியாச்சா? மேல ஊத்துனியா தண்ணி?
Okay.
மேல வித்து பொறுத்ததுக்கு மட்டும் ஊத்தாண்டா.
Okay, so go to the next slide, please. Not previous slide, next slide after this. Okay, so you said you checked for levator ani tone is 3/5. Okay, go back to levator. How do you check for levator ani tone?
Levator ani tone we can able to check by finger into the vagina.
Finger, sorry. It's not clear. Your voice.
Pubo vaginalis. I think the levator and I told ma'am, we have to put these fingers into the vagina 3 to 4 centimeter above the posterior hymen, and we have to look for the resting tone, and as well as ask the patient to contract, ma'am, and see for the tone while straining also.
Okay.
That is, we are activating the pure fibers of the pure vaginalis fibers of the levator ani. With labia major or labia thumb over the labia majora and 2 fingers over the posterior lobe.
Okay, very good. So you will pinch one side of the perineum with your one finger inside. You will be feeling, like you said, within the hymenal margin about 3 centimeters, and one thumb maybe on the perineum, and see how it is contracting. Very good. Now, if you go to your previous slide, you put the pop cube and go to the previous slide. Go to the previous slide. Okay, see, there is no mention of many things in this. Okay, would you be able to tell me? You have not palpated and said what you're feeling in the anterior vaginal bulge. You have not palpated and said what you're feeling in the posterior vaginal bulge. Are you feeling bubble loops? Yes, no, that you have not documented. Okay, second thing is, when you have done a palpation, you should also, after you have reduced the mass, you should also say whether there is occult stress urinary incontinence or not. Okay, how do you check for occult stress urinary incontinence?
After reducing the pelvic organ prolapse, we ask the patient to strain, ma'am. If the
patient to cough, not to strain. Ask the patient to cough.
If the leakage of the urine is present, it's called occult urinary incontinence, ma'am.
Okay, so what is the importance of this in your management?
We have to, if it indicating the bladder neck, we have to when we see for the history of pelvic organ surgery for the stress urinary incontinence is also needed, ma'am. Or else the patient will present with stress urinary incontinence.
Okay, that is one point. Second thing is, at present, she may not be having stress urinary incontinence because of kinking of the bladder neck. Okay. Somebody,
Yes,
Dr. Guna from the audience have said that the after surgery patient may complain of stress urinary incontinence. That's a very good point, Guna, because this is something that's important in counseling. Otherwise, she will tell you, you did surgery for me and now I have stress urinary incontinence. So even if you're not doing a stress urinary incontinence surgery at the same sitting, you should counsel her there is a possibility. So to check for occult stress urinary incontinence is very important. Also, you must palpate the anterior vaginal bulge. You only said about getting above the swelling.
Yes, ma'am.
Not able to get above the swelling. You should also document what are you feeling in your anterior bulge? What are you feeling in the posterior bulge? How do you know there's an enteroseal?
The enteroseal, by demonstrating the enteroseal, ma'am, ask the patient to put in the left lateral position, and we have to put retract the posterior by using the posterior cervix using the valsalum to anteriorly, ma'am. The posterior vaginal wall we have to put as and have to withdraw slowly and see in the posterior vaginal wall.
Okay.
Patient in the dorsal.
What I would expect a minimum from you is, some Dr. Soumya from the audience has said you get a gurgling sound. You feel you're palpating bowel, and there may be that gurgling feel of bowel in the upper part next to the cervix, the upper vagina in its reduced position. Okay, so this is something that you should document. Second thing is, go to your PVPR rectovaginal examination.
When we do the pelvic examination, patient to strain the dorsal artery.
Voice is breaking. Your voice is breaking. Your voice is breaking up a lot. Go to the rectovaginal examination and talk slowly.
Yes, ma'am. Rectovaginal examination. Examination. In the rectal examination, the index finger, the endocyl, it will touch the tip of the finger. The endocyl will feel in the tip of the fingers, ma'am.
See, that's not very practical. Okay, but the minimum you should have said at rectovaginal examination is, are you able to hook your finger into the posterior bulge or not? How do you differentiate between an enterocoel and a rectocoel on doing PR, other than this coming and touching the tip of your finger?
Ask the patient to strain. If there is no enterocoel, we will palpate nothing in between the two fingers, ma'am. If there is an enterocoel, we'll have the gurgling sound between the two fingers.
Okay, that is good. So when you're doing a rectal examination for an enterocoel, you won't be able to introduce your finger into the bulge. While, sorry, for an enterocoel, for a rectocoel, you'll be able to hook your finger into the bulge. Okay, this is important to differentiate between high rectocoels and enterocoels, because it matters on your repair will matter based on your examination findings. Okay, so this is very important to document. Are you able to hook your finger? The second thing is, you should also check for perineal descent. So there are many elements missing in your rectovaginal examination. All I want you to do is take note of it and correct the deficiencies later. Okay. All right? Okay.
Pushpalakshmi, is it always possible?
Perineal descent is very important because in one of the classification, New York classification, they include perineal descent also. So unless you document about the perineal descent and I don't do the repair properly, she may come with recurrence again.
Okay, ma'am.
Pushpalakshmi, is it always possible to differentiate rectocoel and enterocoel by your rectovaginal examination? Is it possible to differentiate between the enterocoel, or is it always possible to diagnose the enterocoel by the rectovaginal examination? Priyadarshini?
By perspective examination, we can able to find better than the rectovaginal examination, ma'am.
Approximately, you can see by putting a sim speculum, you can say when there is an upper bulge, it is an enterocoel, and the lower bulge, it is an rectocoel. But sometimes it may be difficult to identify the enterocoel pre-operatively. It's very difficult. So what is the next alternative investigations to find the patient has enterocoel, because you want to decide, especially in the recurrent prolapse case?
Transrectal ultrasound.
Perineal, very good.
Perineal ultrasound.
Right. Proceed.
Yeah, before that, about the SIMS, tell me
Hello,
few.
hello.
Hello, am I audible?
Yes, ma'am.
But you are.
Hello, Anjalakshmi here. I just Lily, excuse me.
Yes, madam. Yes, madam.
Just to not tell them how to look for the perineal descent.
Okay, okay, madam. So you want me to tell them about how to look for perineal descent?
Yes.
Okay, so one of the important things is to do a Valsalva maneuver. If you find the perineum when you do a Valsalva maneuver should be able to withhold the pressure generated. If you find there is ballooning out of the perineum and the perineal body is descending to a point of 2 centimeters or more beyond the plane of your ischial tuberosity, it is called excessive perineal descent, which indicates a detachment of the perineal body from the rectovaginal fascia. The other important thing is when you do a PR is to try and insert the finger onto the perineal body to see if there's something called a perineal rectocoel. If there is a defect, a bulge in the perineal body can also be a perineal rectocoel. There can be a defect. which is quite rare, of course. So the commonest is a posterior vaginal bulge is a rectocele. The second commonest is a hypermobile perineal body, which is perineal ballooning and excessive perineal descent. It's quite rare to have a perineal rectocele. The most commonest is a deficient perineum. Having said that, what is the normal length of a perineal body? Can Priyadarshini answer me?
3.84 cm.
3.5. Yeah, so from the audience also we are getting answers. So anywhere correct from the audience, anywhere 2.5 centimeters or more. But if it is more than 4 centimeters, then it is an extra long perineum. Okay. So so you also have to look at the perineal body. This is very important because a deficient perineal body may involve an old anal sphincter injury which has been unrecognized. So very often this is also something you may have to address at your surgery. So it is very important to address all these issues. So I think somebody in the audience asked, how do you know about ballooning of the perineum? To please describe it once more. Patient should be asked to do Valsalva and strain downwards if the perineal body descends to a plane more than bulges outwards or descends to a plane more than 2 centimeters beyond the level of the ischial tuberosities of the patient. It means there is excessive perineal descent, which is suggestive of a detachment of the perineal body from the rectovaginal fascia. Okay, so this is just how to repair and how to re-establish level 3 supports. Okay, go to your next slide, please.
Thank you, Lily. Thank you.
Thank you, madam. Go to your next slide. Now I have a problem with this. Can you tell me what the problem is about the level of defect? What all levels of defect does she have?
Level 1, ma'am, level 2.
And
level 3 also.
Yes.
Level 2, you have to again subdivide into level 2A and 2B. Okay. It's not enough if you say only level 2. It has to be again classified into level 2A and level 2B, anterior defect and posterior defect, which has to be staged according to the POP2 classification, right?
Okay, so here just to be clear, we are talking that she has almost total vaginal eversion, stage 4 pelvic organ prolapse, which indicates a loss of support at level 1, level 2,
Level 2, level 3.
and level 3. Okay.
Yes, ma'am.
Okay. Continue, please.
Okay.
You have to say about the levels. They might not be knowing. Again, you can just tell them level 1, level 2, A, B, and level 3.
Level 1 is usually the level 1 defect. Level 1 is usually it is supported by the uterosacral ligament and paracarpium. So whenever there is a defect in the level 1, there may be a uterine descent, or in the case of hysterectomy, vault prolapse with enterocele. So whenever there is a defect in the level 1, the result will be either uterine prolapse with enterocele or vault prolapse with enterocele. The level 2A, the 2A support is formed by the pubocervical fascia and its attachment to the arcus tendinous fascia pelvis. It is again divided into central cystocele and lateral cystocele. Central cystocele is the distension cystocele due to the defect in the central pubocervical fascia, whereas lateral cystocele is called displacement cystocele, which is due to the defect in the attachment of the pubocervical fascia to the white line of the pubis. Level 2P is due to defect in the attachment of the rectovaginal fascia to the arcus tendinous rectovaginalis. That result in the rectocele. And level 3A, when there is a defect in the urethral ligament support, pubourethral ligament, that results in the stress urinary incontinence. Level 3P is the fusion axis defect. So whenever there is a defect in the perineal body, that results in the hypermobile perineal descent syndrome or perineal body deficiency. This is how the level of defect has to be classified and should be managed.
Very good, Sita. Very clear.
Thank you.
This is
Thank you
called
very much.
what? By whose name does this go? Levels of support?
E-Lancet classification, ma'am.
So you should all be able to draw a basic diagram because a diagram speaks multiple words. Okay.
Yes, ma'am.
So if this comes for you as a short note, you should all
Okay,
be
ma'am.
able to draw a basic line diagram and to label the areas of different support. Okay.
Okay,
So
ma'am.
Dr. Shashikala from the audience has said a lateral cystocele cannot be demonstrated by POC.
You can make the cystocele when you see a loss of rugosity on the lateral side. That means that it is a lateral cystocele. When there is a rugosity is present in the midline, mostly the loss of rugosity on the lateral side will be indicates that the defect in the detachment of the pubocervical to the white line of the pubis. Suppose if you don't see the rugosity in the central middle part, then it is most probably due to the midline defect of the pubocervical fascia. It's very simple.
You can also demonstrate by just pressing a sponge holding forceps. If you just
Ringed
press in the
forceps.
middle, there will be two bulges on either side. It's more of lateral cystocele. And if you press on either side, if the central bulge comes out, it is more of central cystocele. Because it is important in the management of repair of
Cystocele, ma'am.
cystocele.
Yes.
Yes, ma'am.
Continue.
Continue, Priyadarshini.
Yes, ma'am. By doing the basic investigation, ma'am, we have to evaluate the patient, the complete hemogram, and renal function test, ma'am, and USG pelvis with USG pelvis and abdomen using the pre-void and post-void.
What is the role of USG pelvis, ma, in this?
You don't look for a kidney, ureter, and bladder.
Yes, ma'am.
Why
Abdomen
that is
and pelvis with
important?
the KUB, ma'am.
So it's not only for the mass abdomen or mass in the pelvis, it is also the evaluation of the renal function also.
Renal function. Yes, ma'am.
In USG organ.
Sorry, madam. So what way, yes, we got an answer from the audience. What way does it affect to the two people who are presenting? What way does it affect renal function? How can it affect renal function?
Due to the prolapse, the dragging of ureter and will lead to the HUN, hydronephrosis.
And which type of prolapse hydronephrosis is common? It's more common in prosidentia because
Stage 4
the ureter also will be drawn towards the
along
vagina.
with the prolapse, ma'am. There will be kinking of the bladder and there will be hydroureteronephrosis, ma'am.
And Soumya, one thing I want to tell, please always stage the pelvic organ prolapse like stage 1, not grade. Please don't mention grade 1, grade 2. Please mention stage 2, 3, 4, please.
Okay, so you will do an ultrasound, okay? In any other situation, can you please tell us in what way when an ultrasound help you? So I am asking you in a post-hysterectomy vault prolapse, will a pelvic ultrasound help you in any way or not? Post-hysterectomy vault prolapse.
Yes, ma'am.
So in what way will it help you? Okay, so the examiners are giving exams now. Okay, anybody from the audience can also answer. Okay, so, okay, let me not to waste time. Adnexial mass, a person has answered yes. If you want to know there's an associated adnexial mass. The second thing is you cannot in a post-hysterectomy vault prolapse because there's no uterus to divide it clearly into anterior and posterior components. You can have an enterocele which presents as an anterior bulge. Okay, you may have a cystocele which presents at the vault. So if you want to know what is the content of the bulge, a pelvic ultrasound can also help you for this purpose in a post-hysterectomy vault prolapse. By and large, in a person where the uterus is there, it is divided by the broad ligaments and the attachments of the uterus clearly into anterior and posterior segments. Okay, and there you are less likely to have an enterocele coming anteriorly. Okay, less likely. Okay, next, continue.
I just want you to tell the postgraduates whether it is necessary to empty the bladder before doing the POPQ or otherwise.
So what I would say in most cases, if you have a very large bladder, it can interfere with the descent of the uterus. So what we would say is do a POPQ to answer your question, Madam Vijaya, with a comfortably full, not with an excessively full where there is urgent, but if comfortably full bladder to check for stress urinary incontinence, ideally speaking, then you should ask the patient to empty and come back and re-examine. So we will accept if you say, I have examined her on empty bladder, but then I will ask you, how will you demonstrate stress urinary incontinence? So then you should say, for stress urinary incontinence, I would re-examine her with a comfortably full
bladder.
Okay, because if your bladder is over distended, then it may actually prevent you from demonstrating the full extent of uterine descent. So that is important to understand. Continue.
Continue.
Yes, ma'am.
Don't waste time.
As a routine, we have to do a viability. If it is positive, go for a colposcopy, ma'am. And then we have to plan
What
for
is
a
the role of
surgical
pap
correction.
smear? Would you like to do a
Pap
pap
smear.
smear?
Hmm.
Or viability is enough?
Viability is enough, ma'am. Here the cervix is lying outside the introitus.
Yeah,
Yes.
because the desquamated cells may not be available.
Yes, ma'am.
That
Then
is the
we are free
fallacy of pap smear.
Yes, ma'am.
Free of evaluation, including the thyroid function test, ECG, and the chest X-ray.
But in Western standards, pap smear is still in vogue, ma'am. So maybe in exam, North Indian examiners, they will expect the students to say pap smear rather than via. That's what I feel.
I would expect them
yeah.
to say pap smear, madam, because
Yeah, pap smear, but what is the fallacy? Fallacy is sometimes you may ultimately miss the, because there is no desquamated cells.
there's drying artifact. So
Yeah.
that is true. But in addition to that, you can also do a VIA and VIA,
Yes,
and VIA.
yes.
But if you feel there is something, so in which cases would you want to do a VIA and VILI? I mean, we should not be using words like that, but visual inspection with acetic
Glucose
acid.
iodine is again not there. Let them not say the villi, madam, only via. As
Yes,
for the
so-
latest composition.
So in what cases would you do it? Now you are seeing the cervix lying outside.
Outside the index. If it
Yes.
is a chronic there is a chronic cervicitis, ma'am. There is chronic lacerated cervix. If there is a cervical discharge present.
Okay, I'm going to stop you, ma'am, because many people from the audience are giving the answer. They're saying decubitus ulcer. See, when you say cervicitis, okay, you are talking about a histopathological examination. You're saying laceration. These are all old lacerations. They make no difference. What you should be saying is there an ectropion or there is an unusual shaped non-healing ulcer or a chronic decubitus ulcer? Then in those cases, you are more worried about a malignancy. What is a decubitus ulcer? Can you tell me, Priyadarshini?
Yes,
What is it? What is a decubitus ulcer?
In a chronic long-standing ulcers, chronic long-standing prolapse, there will be venous congestion in the dependent part, which will lead to anoxia of the tissues and lead to ulceration.
Yes. So very much like a varicose vein ulcer. So there is congestion, there's venous congestion, and there's this breakdown. So there's epithelial breakdown. So if it is non-healing, or if I look at a chronic long-standing ulcer, and I say this looks like a malignancy, how will I know that looks like a malignancy when I look at an ulcer?
By examining the ulcer, edge of the ulcer, and the base of the ulcer, and the induration of the ulcer, extent of the ulcer, we have to see, ma'am. We have to differentiate it by the biopsy from the edge, confirmed by edge.
Very good. Very good. Even the audience is answering. A biopsy, in those cases, a biopsy may give you a better answer. Now, VIA and VILI is also used in low resource settings where you may not be able to see an obvious ulceration. But if the cervix feels hard, it feels globular, it looks unhealthy. So then you are doing it to pick up pre-malignant changes. But an ulcer may be frankly malignant and you will need to biopsy that from the edge. Anuradha madam, anything else, madam?
Yeah, I would also agree
At
with
the
you. If
same
there is
time,
an
we can
ulcer, you
ask,
should always go in for biopsy.
Biopsy.
No, if
Yes,
there is
ma'am.
an ulcer, you should not mention pap smear.
Okay,
Yes, I
ma'am.
agree with you.
And what about the treatment we can ask now itself, I feel. For the decubitus ulcer, for the postgraduates,
Yes, ma'am.
The venous
how do you treat?
by packing, ma'am. Packing of ulcer with glycerin and max sulfate. Regular packing of ulcer.
Packing of the
Vaginal
ulcer,
packing.
you have to reduce the prolapse
Prolapse.
and then pack with what?
Glycerin and max sulfate.
That is to reduce the edema for irreducible prolapse. Maxilf is for irreducible prolapse. For healing of the
Estrogen-
decubitus ulcer, you have to use,
Estrogen creams can also be used, ma'am.
that is for atrophic vaginitis and dry scaly vagina.
Betadine with betadine
Not
solution.
betadine, it is
Acridine flavin
acreflavine.
used previously, ma'am.
Acreflavine,
Flavin
we should
used
say
previously,
only
ma'am.
acreflavine. Yeah.
So all these measures are useful. Why are you packing the vagina?
To reduce the venous congestion, thereby during the surgery, we'll be able to get the pain clearly, ma'am.
No, it is not to reduce venous congestion. You are doing it to keep the reduced mass in place.
Yes, ma'am.
Okay, to prevent a recurrent prolapse, which then reduces venous congestion. The
Then
pack
And
by
to
itself
avoid
doesn't do.
exposure. One of the cause for
Friction.
decubitus ulcer is exposure.
Exposure. Yes, ma'am.
Friction
Friction
keeping it
will cause the
inside. and-
keratinization.
Yes.
The second thing is in large decubitus ulcer, you have to be aware that when if you put a pack and there is infection, it can result in secondary infection.
Infection. Yes,
So
ma'am.
it is very important to pack it so that you reduce it. What is the alternative if they have an infection? Can you put in something else which causes less infection than a bandage or a gauze
Sling
piece?
pessary can be given.
Yes,
Can
a
be done as a
pessary.
conservative management, ma'am.
A pessary can be given.
Sling
In
pessary.
what women will a pessary hold in everybody? So Dr. Arvindin from the audience, Dr.
have to-
Pratibha also saying pessary. Very good. What?
We got to get the correct appropriate size of pessary, ma'am. Due to the lax perineum, there's a high risk of expulsion of the pessary will be there, ma'am.
So in anybody, the recommendation for first line is to use a pessary in all women, even if they don't have a decubitus, to prevent a decubitus.
Okay, ma'am.
What is the essential prerequisite? You should have a good levator, anite tone, something that's able to hold it in. Otherwise, it may
Yes, ma'am.
come out. Just to give you all an idea about this, or when you are deferring further treatment. Okay,
Right.
continue.
And we have to plan for a surgical correction, ma'am.
She is a 63 years post-menopausal, completed her family, will go for
We have to do a vaginal hysterectomy along with the anterior
Ma,
colporacum.
stop.
Ma'am.
Why are you talking about completed family in a woman who's long postmenopausal?
menopausal.
Is it necessary to say
No, ma'am.
completed family?
Yes.
Okay, now she is a 63-year-old postmenopausal woman not living with her husband.
When
So why are you talking about completed family? So don't say things out of reflex, okay?
yes, ma'am. Yes, ma'am.
Okay, so now I will ask you, are you expecting IVF in this postmenopausal woman? No. So don't provide us entertainment, okay?
Yes,
And get
ma'am.
yourself into trouble. Okay. So please don't say that. So
Yes,
what
ma'am.
is your plan? Tell your plan, repeat.
Yes, ma'am. We have to plan for a vaginal hysterectomy along with anterior colporaphy with the posterior colpoperineoraphy with apical suspension, ma'am. Sacrospinous fixation along with the
Okay, so in one word, if you asked what surgery will you perform, you said surgical management.
management.
Okay, one word. What is the word for vaginal hysterectomy, anterior and posterior colpoperineoraphy? One surgical name.
Ward-Mayo's hysterectomy, ma'am.
Yes, very good. Okay, so Ward-Mayo's hysterectomy was the old term used to describe all this in a single word. Okay.
Yes, ma'am.
Anuradha
Someone
madam,
has said
Geeta madam,
site-specific repair also.
Yeah,
Yes,
side
ma'am.
space.
Specific.
I just want, both Sita and Lily to explain. Should they say, I will do site-specific repair, or should they go for hysterectomy with site-specific repair? That is a terminology. What should they use?
Okay, madam, I'll just explain. There's a
I
good
will
paper.
tell. But generally speaking, you have to, the postgraduate should answer vaginal hysterectomy with anterior colporaphy, posterior colpoperineoraphy, and apical suspension procedure. Site-specific repair is mainly used when the patients have isolated cystocele or isolated rectocele without level 1 defect. In such cases, we may go for the site-specific repair. In that scenario, that answer is perfect. But in this case, this anterior colporaphy and posterior colpoperineoraphy with apical suspension is enough.
So I would like to add to it. One thing is, if you look at the recent position statements, many people talk about a colporaphy being better, that is a vaginal plication of the supporting fascia, pubovesicocervical fascia, anteriorly, posteriorly rectovaginal fascia. However, if you see a large tear in a specific area, you should combine both repairs. Having said that, in a 63-year-old post-menopausal woman who is not sexually active, who is not planning on further marriage or sexual activity, is there another option other than doing this Ward-Mayos plus sacrospinous fixation? Is there another option?
Yes, ma'am. There is an obligatory procedures can be done. That is the total colpocasis, ma'am.
Okay, colpoclesis can be done, can be offered to this patient. Why are you offering a colpoclesis? What is the advantage over a reconstructive surgery? So you can divide surgeries into what?
Reconstructive procedures and obliterative procedures, ma'am.
So restorative and
obliterative procedures.
Okay, so when you are restoring, what are the functions you are restoring, particularly when you do a vaginal hysterectomy and you're retaining the vagina? You're
restoring the anatomy
and
sexual.
Bladder function, bowel function, and sexual function.
Okay. Yes, so by restoring anatomy, you are hoping to restore all these three functions. Bladder, bowel, sexual, as Chita Lakshmi told you. So when you're doing an obliterative procedure, you are restoring function, but you are obliterating vagina and preventing coital function.
Yes, ma'am.
Okay, so you should be very clear in your counseling. But what is the advantage over doing all these other procedures?
Shorter time period, ma'am. If the patient is unfit for the surgery, the duration of the surgery is less with the obliterative procedure. As a hysterectomy, there will be less intraoperative blood loss in the obliterative procedures, ma'am.
Very good. Another important thing in the post-operative period, there is less chance of recurrence.
Recurrence, yes, ma'am.
Okay, so there's less chance of recurrence. So you have here, so this is why we tell you to look at the patient as a person. You have a lady who's coming from poor socioeconomic background, who cannot find help or support for her. She has no pension. She has no social security. She cannot keep on coming back for surgery again and again. And her family may not support her. So you want to give her the best possible procedure which restores the functions and prevents recurrence. So colpoclesis should be another one of the procedures which you offer to this patient. Okay, so when you are talking about a sacrospinous fixation, you said you want to restore the apex with the sacrospinous fixation. Yes, what are the risks of sacrospinous fixation? What are its advantages?
The sacrospinous ligament, it arises from the ischial spine. It's surrounded by the deadly anatomy. So during the sacrospinous fixation, there is a more chance of frontal nerve injuries, which lies posteriorly, and it is superiorly by the inferior gluteal nerve and hypogastric vessels and nerves, and inferiorly by the iliococcygeus muscle, and medially it is related to the rectum.
Okay, and stop. Okay, we need a small answer. So you can say injury to the
pudendal nerves and vessels
that go to the pin structures. What are the
pin structures? Yes,
okay, so you know that's the pudendal vessels, the nerve, etc., which are winding around the ischial spine. Okay, so if there is nerve injury, it can cause neuralgic pain. If there is vessel injury,
hematoma,
hematoma and very excessive bleeding can even result in death. It can be very difficult if the blood vessels retract. Okay, so the sacrospinous fixation as an apical suspension procedure should be done by somebody who's a little more experienced in the field.
Yes,
As an ordinary procedure, when you are doing vaginal hysterectomy, if not in a procedentia, anterior posterior corporaphy, what procedure would you use to suspend the apex?
Yes, we have to do a McPass scaldoplasty, ma'am.
Very good. Okay.
Attaching,
Scaldoplasty.
attaching the, yes, ma'am.
And somebody also said in the audience, Dr. Sola Rajalakshmi said vaginal access. That's a very good question because you have to restore the normal vaginal access. Okay. So how do you do McCall scaldoplasty? What are the different types of McCalls you know about?
Yes, ma'am. The internal McCalls, ma'am. Internal McCall scaldoplasty and the external McCall scaldoplasty.
Okay.
We have
Describe what is the difference between the two?
External McCall scaldoplasty, we are doing during the vaginal hysterectomy. We start from the left to right, from the left to uterosacral, from the left to vaginal wall.
Difference between the two? I'm not asking how do you do the procedure. What's the difference between internal and external? Yeah, the person has answered from the audience.
The posterior peritoneum. Peritoneum is not.
No, the peritoneum is included in
Not
both.
included in the external.
The vaginal epithelium is included into an external McCall scaldoplasty.
Yes.
While the internal is only obliterating the entire enteroceal sac, including the uterosacrals.
Yes, ma'am.
Okay. So it is important to know if you're planning to restore the vagina, you have to do a external McCalls, which also supports the vaginal apex. If you're planning to do a colpoclesis, you may just reduce the sac like an internal McCalls and then do a colpoclesis. Okay.
Yes, ma'am.
So it's very important. What is the danger of doing? Do you know of any other suspension, apical suspension procedure?
Yes, ma'am. High uterosacral ligament suspension, ma'am. And another one is, yes, ma'am. Iliococcygeus ligament suspension.
Iliococcygeus. Okay. Iliococcygeus will be restored. There is a difference, and that should be your last option because that does not provide as good suspension as the other.
Yes, ma'am.
What is the danger with the uterosacral ligament suspension? We got an audience from Dr. Arvindan in the audience who said sacropexy. Okay, sacrocolpopexy. Yes, that is also an option, particularly if you have to do it.
Young women.
Associated abdominal procedure.
Abdomen procedure.
Okay. So, what is the danger with the uterosacral suspension, high uterosacral?
The vaginal vault is suspended with the uterosacral ligament, ma'am.
No. What is the important structure which will get injured when you do the intraperitoneal high uterosacral ligament suspension? What should you be very careful when you take a stitch in the ureter?
Okay, ma'am.
So the ureter is very close to the uterosacral ligament. So when you go caudally, the distance between the ureter and uterosacral ligament is very greater than the distance proximal. When the relation of ureter and the uterosacral ligament, when you go cranially, the distance is greater, and in the caudal position, the distance is very lesser. So you should be very careful when you take the bite in the uterosacral.
Yes, ma'am.
About the excision of the excess peritoneal sac, is it included in the McCall's scaldoplasty? Both of you can tell me.
Madam, in a routine McCall scaldoplasty, it is not, the peritoneal sac is included, but you do not excise it. But if you find a deep enteroceal sac, a very deep enteroceal sac, particularly dissecting into the rectovaginal septum, the peritoneal lining should be separated and the sac should be excised. Otherwise, there can be a possibility of a redundant dead space and a recurrence. Dr. Madam Sita Lakshmi, madam, anything?
Only in cases of stage 4 large precedentia with a large, huge pouch of Douglas. In such cases, as per the guidelines and the latest literatures, some amount of posterior vaginal wall along with peritoneum can be excised before doing the McCall's scaldoplasty, which I follow only for stage 4 precedentia.
What about bilateral sacrospinous fixation?
Bilateral sacrospinous fixation has no role. It has an equal result that of the unilateral sacrospinous fixation. So it is enough to do the unilateral, especially the right sacrospinous fixation, because the axis is deviated to the right side. In bilateral, there is more chance for shortening of the vagina, and there is no need because both the results of bilateral and unilateral are the same in a long-term follow-up.
The second thing is, in a right-hand dominant surgeon, the right side is more accessible and easier to do.
Yes, ma'am.
And on the left-hand side, you should also remember the curve of the rectum.
Yes,
the
rectum has more curve on the left side.
Yeah, so there's a possibility of injury is much more on the left side. So a unilateral suspension provides equally good results. The deviation of the axis is not too much, and by doing a bilateral, you're actually increasing the risks to the patient with no improvement in results. Are the students clear about it?
Yes, ma'am.
Okay, thank you. So, okay, continue. So if you are doing a vaginal hysterectomy and an anterior colporrhaphy, posterior corpoperineorrhaphy, what are the risks? What are the risks you will counsel the patient about?
The immediate risk, ma'am, the intraoperative hemorrhage will occur and injury to the adjacent organs, ma'am, bladder and the rectum, and the adjacent organ injuries and the nerve damages, ma'am, which result later on the neuralgia can occur.
This is complications of vaginal hysterectomy. In late complications, we'll counsel the patient regarding the recurrence of the prolapse. If the patient is sexually active, she may have dyspareunia, ma'am.
Okay, so that is very, very important to understand that you can injure the adjacent viscera. So if you find a case of precedentia, would you consider putting Anuradha, madam?
Yes, yes, go ahead.
Please ask, madam. I'll ask next.
No, the same question. In case, what are the post-operative complication? What is the post-operative care? These are the routine questions asked in the examination. Okay, go ahead, Lily.
Also about catheter, I just want them to tell me when will they remove the catheter after a very good repair of anterior colporrhaphy.
Preferably, ma'am. On the day, fourth day, we will remove the catheter. The pre-void and post-void,
Day
ma'am.
4.
48 hours.
48 hours after the surgery with pre-void and post-void, ma'am.
48 hours is sufficient in a very large prolapse.
Okay, ma'am.
There's lots of dissection, pelvic pain, or you're doing associated sacrospinous fixation. You may keep it maximum 3 days.
3 days.
However, as you said, it's a good point. You need to do a pre and a post-void.
Post-void, ma'am.
Is it a must for even third degree UV prolapse to do a post-void, pre-void? We don't do actually, no.
Yes, ma'am.
Students.
Actually, when the cystocele repair is done, it is mandatory to do the discharge the patient by doing the pre-void and post-void, because our hospital is a large volume hospital. We are not doing. But when I do for severe precedentia, the patient is discharged after doing the pre-void and post-void.
Particularly precedentia, you should do it.
No, in the exam, should they say that
Yeah,
even
they
in
should
the
say.
second
They
or third
should
degree?
say. Yeah, they should say pre-void and post-void.
Okay.
If your institution doesn't have it, how will you know that the patient is retaining large amounts of urine? Let's say you're in Egmore, you have a high volume.
Yes, ma'am.
So how will you know from the patient's history that the patient, you're suspecting that there's a high post-voidal residue? How will you know?
Patient says an incomplete sensation of void, emptying, ma'am.
Very good.
Frequent urination, ma'am.
Okay, overflow leakage from the audience, Dr. Arvind, overflow, abdominal distension. So the typical history of overflow incontinence, loss of sensation, but intermittent leakage of small amounts of urine. If the patient has lost sensation, she will tell you she has incomplete voiding or increased frequency of micturition.
Yes,
so clinically, it is possible to detect it, and this should be a question that every postgraduate asks, because this is very important in the long-term outcome for the patient. It's very important in the long-term outcome for the patient, because if you ignore it, it can result in subsequent detrusor hyporeflexia because of over distension of the bladder. Okay.
Lily, for the postgraduate sake, can the stress urinary incontinence be repaired in the same sitting with the prolapse uterus? And if we have done it, and should the catheterization be prolonged?
Madam, that's a very good question. For the sake of the postgraduates, the present
I
recommendation.
am only asking the question, they're scared, I think.
For yes, madam, but if for the postgraduates, what you need to understand, if there's a large prolapse, if there was significant history of stress urinary incontinence preceding to the prolapse becoming large, or when you reduce the significant occult stress urinary incontinence, you should consider procedure at the same sitting. From the audience, people have said, Dr. Soumya said transobturated tape. Yes, mid-urethral slings can still be used, or you can use a pubovaginal sling, rectus sheath, or fascia lata. However, you can always counsel the patient. That is the present recommendation, ideal recommendation. But I would personally speaking, talk to the patient about it. Unless it's a significant quality of life issue, I would not do it at the first sitting. I would tell the patient subsequently, you can come back. I can do a minor procedure if it is troubling you. So it would be a point of counseling, because transobturated tapes has its own complications. And can the students tell me what is the commonest problem with the transobturated tape?
Trans-operated tape, you are entering the, you are not entering the retropubic space, ma'am.
Yes, you're not entering, but what is the problem with it? Okay, so you're not entering, so it is better than the retropubic tape. But what is the problem? Somebody said
What is the
osteitis.
complication? What is the long-term complication of the transobturator tape?
Osteitis is not the answer. Yes.
Yes.
So in a postmenopausal woman, there will be erosion.
Erosion, sir.
Okay,
mesh
so if
can
you've not
come out.
applied it properly.
Mesh erosion. It is not the cervical erosion. Mesh can come out through that operated site.
Yes, ma'am.
And they can sue you also. That is why the mesh is becoming abandoned nowadays.
Yes.
And that is why increasingly, if somebody asks you a question, you need to at least be able to say pubovaginal slings with the patient's own tissue.
Yes, ma'am.
Rectus fascia
or the fascia.
Okay, so to answer the question concisely, if it is a quality of life issue, if there's significant stress urinary incontinence, yes, at the same sitting. If it's not a significant quality of life issue, counsel the patient. You can always bring her back subsequently.
But I also go by the law. If the patient has a large amount of stress urinary incontinence along with procedentia, then the surgery is mandatory simultaneously. Otherwise, I will also prefer to have the surgery for stress only in the later stage, second stage.
What about the repair of the pubovaginal fascia with a Kelly stitch? Will it cure the stress incontinence?
No, Kelly stitch has no role in treating the stress urinary incontinence. The pathophysiology of stress urinary incontinence is the loss of support. Kelly stitch will not help in treatment of the stress urinary incontinence, and it should not be done.
The problem is there's a higher recurrence rate when if it's done, because initially if you tighten too much, there can be higher rates of voiding dysfunction. And subsequently, the failure rates are very high, up to 64 to 70% the failure rate. So it's not generally advised to do a Kelly stitch at the bladder.
Also, if the Kelly stitch is, very high, may even cause retention of urine also. So it is outmodal.
Tightened, yeah. So the postgraduate should understand the excellent repair of anterior colporrhaphy might cure a mild stress incontinence. So you can say in the exam, as Lily ma'am said, if it is not very significant, you can still wait and you do the mid-urethral sling, which is a minor procedure, at a later date. Yeah, proceed.
Okay, so if you have a rectal injury at the time of repair,
yes, ma'am.
What would you do for the patient? You are doing a colporrhaphy and you have a rectal injury.
You have to do the simultaneous correction.
Okay, you have to do a simultaneous repair. If the vaginal epithelium is very thin, if there's a large injury, what additional procedure do you need to do? Have you heard about a graft? I'm giving you a hint. Take the hint when your examiner is giving it to you. Can you use any graft? Omentum may be difficult. If you can access omentum, fine. Anything else from the local tissues? Something which starts with M? So anywhere if there is an injury and you cannot adequately say I have re-established and there is a good vascularity, you need to increase the tissue interposition. Yes, Dr. Jeevita has given the answer from the audience. The tissue interposition between the repaired site and the vaginal epithelium. Okay, so one is you can use a Marcius graft, which is a labial fat pad.
Labial fat pad. Okay.
Okay, so what is your post-operative? Anuradha madam had asked you, what is your post-operative care? You all only spoke about catheter. What is your post-operative care? Gracilis, okay. That is in a very large injury. Okay. That's from the audience, gracilis graft. That would usually be used as a secondary procedure because that's a much more morbid procedure. A gracilis muscle wraparound. Okay, so to answer, what is your
Suppose the
post-operative
rectal
care?
injury is a little high, they have to go for an colostomy and then
Depends on the site of injury.
only low rectal injury can be repaired at the same time. Otherwise, if it is a high injury, when you are repairing an enteroseal, and if you think the repair injury is at the higher level, better to call a surgical gastroenterologist and go for a colostomy.
Yes, madam, very, very right for all PGs to take note. Okay, please tell us about post-operative care for a patient.
We have to give the adequate analgesic, ma'am, and we have to give the adequate hydration and the catheter care, and the patient should go for an early mobilization, ma'am. And you have to go for a thromboprophylaxis in case of a long duration of surgery, and she's also a old age. And in delayed, we have to
Advise the patient for sexual abstinence.
Laxative?
Laxatives, ma'am.
Okay, to prevent constipation, yes.
What about the pre-operative preparation of the bowel? If you're going in for a rectosil repair, are you going to do a what is the bowel preparation you are aiming at?
And it is very difficult also when there is a huge prolapse with
Yes, ma'am.
how will you give the pre-operative bowel preparation, as madam is asking?
We can start on the patient with a liquid diet on the day before surgery, and we can
Who
give
is written double enema? Double enema is not there.
Yes, ma'am. Peglet sachet can be given 9 hours before the surgery, ma'am.
Now, if you give peg leg, one problem is she will keep passing motion on your table.
Electrolyte imbalance.
Okay, so every time you touch the posterior wall, you'll feel something dripping out, and it's very unpleasant. Okay, so you can either give an enema, but if you give peg leg, it's an electrolyte. Okay, so it causes continuing secretions from the gut. So enema works very well, unless you're thinking in terms of some malignancy or some big thing. So if you want to make the patient think, you can either give an osmotic enema the previous day, or even a plain Dalcolac suppository is sufficient with restriction of food overnight. After you give the suppository enema, tell them to avoid eating. They can stay on oral clear fluids. That is sufficient, and that is all we do in our setup, because otherwise we find a lot of liquid stool which is smearing the perineum and causing contamination of the surgical site. So you all can talk about your experience. Maybe it's different. But an enema works very well on the morning of surgery.
But we have stopped using the enema in all our gynec surgeries. That is why I just thought if there are any recent advances in enema, that also the people should know. They should not think only about OG, because some examiner will ask this pre-op and post-op, all those things, and they'll be stuck. That is why maybe we can refer and tell them, I think, if there are any newer.
The recent guidelines, madam, say that don't do formal bowel prep with these kind of electrolyte solutions, because it can cause contamination. In the OGS Yoga statement, that is what is advised.
Okay.
Not to do extensive bowel preparation as you would do for an endometriosis or something else when you're doing inside. So, but yes, keep the bowel relatively empty to prevent fecal soiling of your perineum.
Maybe low residue diet for a few days before the surgery might help them.
Yes, ma'am.
Okay, proceed.
So what about post-operative care? She's discharged. What would you advise her?
Restrain from strenuous activities and weightlifting for 6 weeks.
What is weightlifting? What is your definition of weightlifting? Because you cannot tell the patient weightlifting. What is weightlifting for me may not be weightlifting for somebody else. Okay, she's a manual laborer. You need to define what is weightlifting for her. Can anybody tell me what is the ideal recommendation? The bottom line is there is no ideal recommendation. So there is no randomized study, no excessive things. So mainly it's anecdotal and you go by intuitive common sense in these situations. So what is the weight you would advise? Generally it is advised less than 10 pounds, that is less than 5 kgs is all, not more than 5 kgs. So what would you practically advise the patient? Don't lift a bucket of heavy water. Don't lift a pot of heavy water. This is a poor patient who may be going somewhere to catch water from a public tap.
Yes, ma'am.
Okay. Or if you have somebody who is working as a housemaid, don't lift a heavy cooker or a bucket. Okay. So these are common practical advices that you would give. Don't lift anything which increases abdominal strain. Why is that? Why is it that we say this advice?
It will cause the recurrence of the prolapse, ma'am. Again, weakness of the
How does it cause recurrence?
Again, the weakness of the pelvic organ supports, ma'am.
Okay. How will it cause weakness? I'm going to keep on asking you how till you start thinking and answer me. Yes, I got an answer from Dr. Arvindan and intra-abdominal pressure. So before consolidation and fibrosis of a wound occurs, there is increased intra-abdominal pressure. It will cause defective wound healing. So you need to know pathology. How does a wound heal? By primary intention? What is the consolidation phase of a wound healing? So these are things you should understand. So how long will you advise avoiding heavy lifting of weights?
6 to 8 weeks, ma'am.
Yeah, at least 6 to 8 weeks until the primary phase of wound healing. But consolidation takes place up to 3 months. Yes, from the audience, Dr. Soumya said 3 months. What else would you advise her in the post-operative period? Something which
avoid straining during constipation, and she can use the laxatives and high fiber diet and plenty of oral fluids, ma'am.
Okay, then one more important thing, which she may not ask you, but you have to address if she has a husband around.
Sexual activity. She should be refrained from the sexual activity for 6 to 8 weeks.
Okay, at the minimum 8 weeks.
8
because
weeks.
you
Yes,
don't
ma'am.
want colporexis and the patient to come with evisceration of any form. Okay, so any giving, the word is called vaginal rest. Yes, Dr. Sole has said abstinence, but abstinence for how long is what we have to define.
Yes, ma'am.
Okay, so any vaginal rest. So if you do a hysteropexy and you have a uterus in situ, she has periods. So you should tell her don't use a tampon. Okay, so if she has a husband around and she doesn't have a uterus, you've done a vaginal hysterectomy, avoid from coitus. Okay, what else can aid vaginal healing in a 65-year-old post-menopausal woman? I'm giving you the hint. Yes, Dr. Adare Selvi has given the answer from the audience.
Hypoestrogen.
Yeah, so what can you give? Estrogen creams.
Estrogen creams.
Yes, I think we're running out of time.
When will you advise the post-operative estrogen? Pushpa Lakshmi, when will you advise, if at all, if you want to advise for the estrogen cream, after how many weeks the patients should start applying the estrogen post-operatively?
After 6 weeks, ma'am. When the patient coming for the follow-up, we can give the estrogen creams.
Suppose
Intraoperative.
So what is the minimum period, minimum post-operative period she should not use? Why it should not be used before that weeks?
The estrogen will increase the local vascularity of the vaginal epithelium.
The minimum period is it should not be used up to 3 weeks post-operatively, because if it is used before 3 weeks, it may disturb the healing of the wound and result in the defective healing. So it should started using only 3 weeks after surgery, minimum of 3 weeks. Okay.
We are running out of time. Lily, I want you to tell about the application of levator RNA, whether it is still in vogue. The second is about the pessaries. Both you should tell the PGs how to use it, how to measure the size of the pessary, and how to maintain it. Cleanliness,
It's very
autoclaving.
important question. Would you do levateroplasty? Okay, or levaterorrhaphy? Anything when you use the term rhaphy means a midline plication. So the levator ani should not be sutured together in a midline in a sexually active woman. That's a very clear recommendation because it may cause posterior ridging and high rates of dyspareunia in a sexually active woman. However, if the genital introitus is very wide, you said 7 centimeters in this lady, which looks very, very wide. I didn't stop you at that point in your POCU. 7 centimeters is a big perineal, is a big gaping of your genital hiatus. Then in those kind of cases, you may need to fix it laterally at the level of the rectal pillars. You may need to fix it, but not do a midline plication. You may need to shorten it. So the routine teaching for postgraduates is no levaterorrhaphy in a sexually active woman. However, a good level 3 repair of your transverse perineum, your bulbospongiosis, your good perineorrhaphy, and a good repair of your rectovaginal septum, looking for discrete tears, reattachment, etc., will suffice. In rare cases, you may need to resort to it, understanding that it can cause higher rates of dyspareunia. What was your second question, madam?
Pessaries.
Pardon?
Pessaries.
Pessaries. Okay, the pessaries, the ones available on the Indian market are ring pessaries. We use it a lot, ring pessaries with and without support. However, using a ring pessary is the first line of recommendation in many Western countries. Many Indian women do not prefer it. However, as the socioeconomic status improves, many women want it. Okay, so you can always use it as a temporary measure. If a patient says, my son's or daughter's wedding, it is not convenient, my child's exams, put in a pessary and send the patient. Two very important prerequisites. You need to have a relatively levator tone to hold a pessary in place, particularly a ring pessary. Otherwise, it will not hold. How do you measure it? You do it just like how you are checking for pelvic adequacy in a pregnant woman. So you would check from the lower border of the symphysis pubis, your diagonal conjugate towards your as high as possible into the posterior fornix. By a general rule, usually a 6 centimeter diameter pessary is what is comfortable in most women. When you insert a pessary, it should not cause obstructive voiding and the patient should not feel it. However, in many stage 3 advanced or stage 4 prolapses with poor levator ani tone, a pessary will not hold. And when you are talking pessary, you prefer a silicone pessary, not a bangle, not a plastic ring, which can cut into the epithelium. You're talking silicone pessary. In those cases, you need to use a space-filling pessary like a cube or a gel horn or a donut pessary, which I have not seen on the Indian market. Madam, Dr. Anuradha, Dr. Sita, madam, have you seen it?
Yeah. No, we have not seen. Gel horn is not available.
Silicone ring pessary.
So basically, we have all seen ring pessaries. We have all used ring pessaries. So the important thing is to put the size approximately in large prolapse. You need anywhere between about 6 centimeters is the most comfortable. You put it in, you ask them to walk around. They should be able to retain the pessary in place. They should be able to void without obstruction. And you need to tell them if it comes out, how to reinsert it, and pessary care should be advised. So many women who have good levator ani tone do very well with it. Even procedentia cases, it reduces the edema, it keeps the prolapse in place. So it's a very valuable part of your prolapse management. And silicone
change every 3 months?
Change, madam. Actually, if a person is using a pessary and if they are agile or even they have a good caretaker, I personally advise to take it out at least once a week, wash it and replace it. But if a woman is young and sexually active, they can remove it during coitus and reinsert it, because the problem is it is a foreign body. So sometimes 3 months we may forget about it. It may erode into the vagina. It may
Need not autoclave. They need not autoclave if they are changing.
just soap and water, just wash it, dry it, reinsert it with, if postmenopausal, use some estrogen cream also and reinsert it. Sita madam and Dr. Anuradha madam.
Yeah, I agree with you. And one point I want to add is the levatorrhaphy is a must when the colpoclysis is done. It has to be done and it is a must. Otherwise, routine levatorrhaphy is not done for all pelvic organ prolapse reconstructive surgeries. And regarding the pessary, I fully agree with Lily, and that is what being practiced currently.
The 2 points, the carry home points of the pessary is, as soon as the correct size of the pessary is inserted, the patient must be comfortably void urine and she is able to walk around. Don't send her immediately. Maybe by climbing, one patient came, as she climbed into the public transport bus, the pessary fell and she came back to IOGOP with the pessary in her hand. So always you should keep her for some time, ask her to walk around and void urine, and then you ask her to how to clean, and the care is very important. As Lily ma'am said, if you forget, it will get impacted, incarcerated pessary, even might lead to vaginal carcinomas, long forgotten pessaries.
Yes, madam.
You want to say anything about the sling, because we are closing, I think. Sling surgeries, few tips or points, both of you, Sita and Lily.
What surgery?
Sling surgeries.
Stop.
Conservative surgery.
Vidya, 1 minute. Vidya, 1 minute. PGs நீங்க share பண்றத stop பண்ணிக்கோங்களேன்.
Yes, ma'am.
So sling surgeries, madam, it is mid-urethral slings are the only acceptable mesh in pelvic organ prolapse surgeries today. No other mesh should be used. It should be a type 1 polypropylene mesh, which means more than 75 micron pore size. It should be a pliable, good quality mesh, not from a local company, which gives you a cheap mesh, which is not very mobile, not distensible. You know, there is a certain quality to the mesh. What are you using a mid-urethral sling or any mesh for? It acts as a scaffolding into which it's like a trellis on which you are growing a creeping plant. You are allowing the fibroblast to infiltrate and develop fibrosis around the mesh. It works as a scaffolding. It's like when you lay concrete, you put a metal scaffolding and you pour concrete on top. So that is precisely what we are doing with a sling or a mesh.
So what about the conservative uterine slings?
Yes, so we can do these kind mid-urethral slings. If you are planning on doing sling surgery for hystropexy, I think madam says the Purindra's method was a very common, very popular method, but it pulls the uterine axis. Okay, so you take the strip of rectus sheath and you attach it ventrally at the level of the isthmus. People who have sling surgeries, it may open up the pouch of Douglas and cause enteroceles. In the present day, if a person has poor tissue, the same type of surgery is done called a Kanna sling. This is another place where prosthetic sling is acceptable. You can take a strip of type 1 mesh, attach it at the level of the anterior superior iliac spine and attach it to the posterior level, posterior cervix at the level of the isthmus. It promotes anteversion. Dr. Piley does an excellent repair. I have done a few. And it provides good support because it's not dependent on the patient's own tissue. Having done any sling surgery, when we are planning to do a hystropexy, we should always see if the cervix is hypertrophied, elongated. You need to do a simultaneous cervical amputation, preserving adequate length of the cervix, especially if the patient is planning to conceive. So it should not be a very short cervix, which results in cervical incompetence. The sling should be adequate to provide prolonged support. So you can do either a Purindra's sling, which is the safest with the patient's own tissue, own rectus sheath. On the other hand, you can use a Kanna sling using strips of prosthetic material which can be attached to the posterior surface of the uterine isthmus at the level of the isthmus, or you can do a sacrohysteropexy. You can attach a sling to the back of the uterus and pull it up and attach it to the anterior longitudinal ligament of the sacrum. However, each procedure has its own peculiar complications, and counseling is a very essential part. In any sling surgery, you are restoring level 1 Delancey support. So you are using your prosthetic material as an artificial ligamentous support of the uterus at level 1. At the same time, level 2 and level 3 supports have to be addressed with a facial repair if there are significant defects. If you just address level 1 apical defect and you do not repair a cystocele, rectocele, the patient has a higher chance of recurrence. If you do not amputate an elongated cervix, there's a higher chance of recurrence. Meshes in today's world are acceptable in only 2 scenarios: introducing an abdominal mesh for a hysteropexy, where you're not entering the vagina, or you use a midurethral sling for stress urinary incontinence. It is not medico-legally advisable in any other circumstances. So, madam, thank you very much.
Thank you, Dr. Lily, Dr.
So
Vidya,
nice it was, very refreshing.
Yeah,
Thank you very much. I owe a lot
very,
to
very refreshing, both from Dr. Sita and Dr. Lily. Listening to another lecture from 2 urogynecologists.
Yeah,
Thank you
me
very
and
much.
Anuradha like
students.
me and Anuradha ma'am like Salman Papaya sitting in the front, and you both are both Bharati and
Raja.
Raja.
Yes.
Madam, I thank
Thank you, madam.
MMC a lot because I trained there in KGH only and I met all of
I
you.
know, Lily. So much nice memories.
Part of the
I
same
hope the
family,
students are really benefited. Any other doubts, you can give it in chat box, and Sambat ma'am will send it to Lily ma'am and Sita ma'am, and we'll get you the correct, because we are not discussed about the father gills again, but then I think they will know the steps. That is out of vogue almost nowadays. That is why we didn't discuss much about the father gills. Otherwise, it was a very, very nice
We
discussion.
take, only one case, Vidya, 2 hours discussion. Solid 5:30 to 7:30, only
Okay.
one case.
Okay.
They should be
Thank you,
இதுவுமே நமக்கு இப்ப father case discuss பண்ண முடியல. Anyway, PGs you presented very well, but you should read again.
Thank you.
Okay.
Thank you.
Thank you so much.
Yeah.
Thank
Thanks
you,
a lot.
Lily.
Bye.
Thank you, Anuradha madam, Dr.
Thank
you,
Vidya,
thank you
Dr.
so much.
Sita, everyone, thank you for your time. Thank
Okay,
you.
bye-bye.
Thank you, ma'am.
Bye.
Thank you.
Thank you. You can PGs join on the next month, last Saturday evening. Thank you. Thank you,
Thank
Vidya.
you, ma'am.
Thank you, ma'am.
And சித்திரக்கலா லீவ் பண்ணிடலாம்.
Yes, ma'am. Yes, ma'am.
நான் நைட் உங்ககிட்ட பேசுறேன். Okay, bye.
Okay, ma'am. Okay, ma'am. Okay, ma'am.